Well, welcome, and thank you very much for coming. Thanks to the BRC for the opportunity to share with you some of the work that we're doing in the field of heart attack and stroke, clinical treatment and research. And what I'd like to do today is to give an overview of clinical management, particularly of heart attack, and then to show you perhaps where some of the limitations are in terms of the diagnosis and treatment of heart attack, and how working with the BRC, the partnership of the university and OUH NHS Trust, are moving together towards improving patient care and patient outcomes, we believe, through a combined research effort. So I thought it'd be worth outlining what I mean by heart attack, because listening to Radio 4 amongst other news outlets, it's pretty clear that there's a little bit of fuzziness in the understanding of what we mean by heart attack and cardiac arrest and so forth. And really what we're talking about, this is a diagram of the heart, which of course is a muscular pump, and it gets its blood supply from principally 3 arteries that lie on its surface. They're called the coronary arteries. And what we're going to be focusing on today is the interaction between the artery, which is susceptible to getting narrowing or blockage with a disease process that we call atherosclerosis or atheroma, and the consequences of those blockages or narrowings, which is a deficit in the blood supply to the heart muscle. So it's quite a helpful concept to think of this in terms of the upstream, what's going on in the artery, what's going on in the pipe, and the downstream, what's going on in the tissue that's meant to be getting its blood supply from that pipe. And the tissue that I'll be talking about today is the heart muscle, otherwise known as the myomuscle-cardium, the muscle of the heart. So I'm going to start with a clinical case. This is made up, but it's very typical in terms of the headline manifestations. A middle-aged male patient who experiences chest pain, typically central crushing chest pain, perhaps radiating to the arm or to the neck. And we see on the ECG something that we term ST segment elevation, and I'll show you what that means in a moment. The patient arrives at the door of the John Radcliffe by ambulance at 10:20, so we have a service which around the clock, day or night, is responsive to the needs of patients having heart attacks. The wire time, I'll show you what that means in a minute, was around 29 minutes. So I put this slide in to add a little bit of pizzazz and some sense of urgency and excitement to the treatment of heart attack in Oxfordshire. The reality is a little bit more prosaic than that, but we are grateful for the collaboration with the ambulance service. And what I'm going to show you is a real team effort from the paramedics that pick the patient up in the community with the diagnosis of heart attack. The paramedics make the diagnosis based on the patient's history and the ECG, and that is then transmitted to the coronary care unit at the John Radcliffe, where the nurses will activate a team, as I say, 24 hours of the day, every day of the year, to receive, ideally, the patient in the cardiac cath lab. So the reason that we operate this system is because there is a very, very sensitive relationship between elapsed time after the blockage occurs in a coronary artery, provoking heart attack and provoking pain, and the clinical outcome. So this is a graph that shows delay along the bottom and benefit in terms of lives saved along the side, the y-axis. And suffice to say that as time goes on, there is less and less benefit in terms of life saved, and that diminution in benefit is particularly steep within the first 2 or 3 hours. So we really want to get on with this very quickly. So the patient will be transferred to the heart centre. The nurse will have activated a team which consists of a physiologist, a radiographer, a cardiologist, 2 or 3 nurses, a medical registrar, cardiology registrar, and we will try to be there to receive the patient as they arrive, not in the emergency department, but directly to the door of the heart centre. We'll transfer the patient immediately from the ambulance into the cardiac cath lab speaking to them as they go, and learning about the presentation and the background medical diagnoses. So we really are trying to do this very quickly, and I'll show you the data that we measure in response, in terms of speed of response in a moment. The diagnosis initially is made from the ECG, and I spoke about this change in the ST segment. But we really only know that the patient's having a heart attack for sure when we get them into the cardiac cath lab. This is a picture of a This is a picture of a patient that's having a heart attack, and unfortunately the video is not going to play. But this is a tube that's been introduced via the femoral artery and looped around the aorta, and it's preformed in such a way that it nestles into the opening, in this case of the right coronary artery, that should have a course along the outside of the heart and is supplying perhaps a third of the heart muscle. In this particular case, the artery is blocked at this position here, and I've put down the artery a wire which you can see outlined in purple, and that wire, which again is threaded through the tube into the heart artery, acts as a rail, and over that rail we can pass all manner of devices that allow us to intervene on the inside of the artery and to relieve the blockage, which is the object. So this particular device has got on it, silhouetted in blue here, a capturing sac. It's like a windsock, but it's sealed at the far end. And the purpose of that is to capture any material that's liberated when we open the artery up. So there you see the shadow of that device. There's the open end, the wire end, placed on the wire. Now in a minute I'm going to deploy within the artery a stent. So this is a stent blown up. Typically this will be between 2.5 and 4 millimeters in diameter, and between perhaps 12 and 30 millimeters in length. So you see it greatly magnified here. And this alloy stent, which is made to have high radial expansile strength to avoid it constricting down within the artery, but to occupy the minimal volume in terms of the metal work that's present there, is mounted on this expandable balloon. So here you see it in its expanded form, but when it's delivered to the artery, it's crimped down and it has a very low profile. So the stent is shown here by the yellow, that's the balloon. That's what I actually see in the cardiac cath lab. So we fill the balloon with a radio-opaque marker that allows us to see its exact position. And then following the delivery of the stent, you can see that this artery is nicely wide open again. It was originally blocked at this point, but now it's conveying blood right the way down into the far end. And that's an effective treatment corresponding to restoration of blood flow and abortion of the heart attack process. This is the device that I showed you. Remember the windsock device, which is open at the near end and closed at the far end. And you can see that in this case, it's caught a couple of little lobulations of blood clot. And if we look at that in close-up, you can see that this contains some of the material of the blood clot which has obscured the artery, and these little yellow friable bits have probably been liberated from the wall of the artery, and they're the atherosclerosis, the furring up, the scaling, if you like, which is the root cause of this problem. So I said to you that we were very keen to deliver this treatment as soon as we possibly could, and we take a lot of trouble to monitor our performance in that respect. So the graphs that you're seeing here again reflect this time along the x-axis in minutes, and this is a cumulative percentage, and the cumulative percentage relates to 3 different things. So the green line is the relationship between the onset of symptoms and the delivery of treatment. And you can see that about half the patients have received the treatment within 3 hours of the onset of pain. So I might say only half the patients have received their treatment within that critical time. The purple line is the relationship between the call to the ambulance service and the delivery of treatment. And the blue line reflects the time elapsed between the patient crossing the hospital threshold and having an effective treatment. And you can see that the 50% of patients have received effective treatment for their heart attack within about 15 minutes of arriving at the hospital. So this is a very, very prompt service. The problem is that we need to communicate more widely the urgency of responding to these symptoms, of calling for help quickly and getting to the hospital. So the big challenge of the moment is one, I would argue, of education. And if you look at these lines, you can see that 90% of patients have received a treatment within an hour of arriving at the hospital. Okay, so it's an effective treatment. It reflects the joined-upness of the paramedics that collect the patient, this transmission of data so that the hospital can be ready to receive the patient, and the effectiveness of the staff in the heart centre in terms of delivering that type of care. Well, what about where the treatment is not successful? This is clearly a post-mortem specimen. I don't know if this patient actually died from heart disease or not, but the dissection of the heart reveals the consequences of myocardial infarction. So if you look up the top end here, this is the left ventricle, which you'll remember is meant to be thick-walled. It's a muscular pump, and it's responsible for delivering blood at high pressure throughout the body. Down at the so-called apex of the left ventricle, however, the muscle doesn't look anything like that. It's thinned out, it's replaced by this white, gristly, fibrotic tissue, and it won't be doing anything, it won't have been doing anything in terms of delivering effective pumping activity in that patient before death. So this is what we're trying at all costs to avoid. Increasingly, we're using sophisticated imaging, and this is an MRI scan, to assess the pumping function of the heart and to glean other important information about both heart structure and function. So this is also a patient in whom there has been an established heart attack, and I'm going to draw your attention to this. So these are the 4 chambers of the heart. Here's the left ventricle, which is the pumping chamber. This is the right ventricle, which has only to pump blood to the lungs. And at the top are the 2 atria. So you're seeing all 4 chambers of the heart in cross-section. The white in the center is blood, and we see it as white not because we've introduced any exogenous contrast material, but because the MRI technique is clever enough to pick up the blood as white in this particular sequence. The heart muscle down here, along the so-called lateral border, is moving more or less normally. But you'll readily appreciate that this portion of the heart muscle is completely static. So this is the consequence of myocardial infarction, seen now not in a post-mortem sample, but in vivo in a real patient. One of the other consequences of heart attack is that the muscle becomes, if you like, scuffed up and inflamed. And sometimes we see adherent to that scuffed up muscle a blood clot. And this round golf ball-like structure here is a blood clot which is adherent to the damaged internal surface of the left ventricle. Okay, so I've shown you to some extent what is the normal pathway of a patient coming into hospital these days, and I've shown you how we can respond to changes in the ECG. We get some information from some blood tests, and we get further information from an angiogram. This is what I failed to show you on the video, the blocked coronary artery. But actually, these tools, although we use them every day, are relatively crude in terms of what they can tell us. They don't tell us very much at all about the extent of damage to the heart at the time of presentation. They tell us even less about the extent to which we might be able to recover function in that threatened muscle over time. They don't tell us anything about the patient's propensity to develop bad heart rhythms, either acutely or down the line. So there's a lot more we would like to know, both about the upstream, about the causative problem in the artery, and about the downstream, what's going on inside the heart muscle. Okay, so at the moment, we're very much making do. And what I've put here on this text slide is, if you like, a clinical wish list. We'd like to be able to characterize tissue. We'd like to be able to know what's happening physiologically and how that relates to the things that we measure in the blood. We'd like to know about these things we call now omics platforms, very complex ways at looking at gene expression and multiple metabolites that are made by tissue that's deprived of its blood supply. And you can read the rest on the slide for yourselves. Quantification of disease, what's going on? What's the burden of disease? Is it active or is it inactive? We're in a quiescent state or a very volatile state. All of these things are insights that we would like if only we had sophisticated enough diagnostic tools to give us the insights. So to approach this, we have in Oxford, funded by a consortium of the Medical Research Council, the British Heart Foundation and the Department of Health, recently opened a unique centre. So this is, we believe, internationally unique, truly unique, in the sense that it has equipment which is configured in a certain way, and I will explain more what I mean about that in a moment. But more than that, the equipment is plugged in to an emergency setting situated as it is between the emergency department and the heart centre. And the idea of this new centre is that we can take patients in the very first hours and minutes after heart attack or stroke, and we can deliver to those patients exactly the care that they would receive and would expect in the main hospital, but in an environment that would allow us, with appropriate consents, to undertake some research in the emergency setting so that we can learn more about the early evolution of disease and of its manifestations, and we can monitor the effects of novel interventions. I should emphasize this is very much a partnership between colleagues in the university who perhaps are developing novel techniques, novel sequences, and colleagues in the hospital that are delivering the high quality service that I outlined to you a few moments ago. The staff that are delivering the clinical care are the exact same staff that would be delivering it were it not a research environment in the heart centre, and the equipment that we use is more or less the same as the equipment that we would be using in the heart centre. And those features, I think, are very important to emphasise. So the idea is that we will build so-called prospective cohorts. We will, as far as possible, enrol all patients who are coming with acute stroke or acute heart attack, again subject to the usual checks and measures and appropriate consents, so that we can learn about the full spectrum of disease. We will characterise heart attack and stroke in those patients with a whole range of blood tests, some of which are established and some of which are being newly developed and newly understood. And we will also use a range of sophisticated imaging, of which more in a moment, to characterise exactly what's going on in a stepwise fashion. So often patients in our early studies are having sequential imaging so that we can really understand what's going on in the heart in terms of the evolution of the disease. We're projecting that at full occupancy we'll be running around 1,200 scans per year in the Acute Vascular Imaging Centre, and we're currently, even since this slide was prepared, increased from around 600 per annum to around 750. So this is a very active and very busy centre. The Biomedical Research Centre underpins a lot of what we do, both in terms of funding some of the core staff, coordinators, nurses, IT support, but also helping us to really get the most out of the NHS resources that are already in place. What do I mean by that? Already, as part of our routine clinical care, we collect very detailed data on all sorts of things, from time to presentation, clinical data, blood pressure, cholesterol, diabetes, and so forth. But if we want to use that for research purposes, so that we really have very thorough characterization of our consenting patients, then we need to be able to harvest those data in a way which is research appropriate. So one of the things that we've done with BRC support is to mirror the clinical databases with a pseudo-anonymized database, which allows us to access in research appropriate form a lot of data that was previously invisible to us, and to be able to search that and to integrate it with our research data. So that means that the clinical databases now become a very important and very powerful research tool. So this is the centre in action. You can see this is the cardiac cath lab table of the sort that I showed you in one of those very early slides. So this is the place where we deliver treatments to blocked arteries. But this table is a platform which, in a mechanised fashion, allows us to move a patient directly from the cardiac cath lab, where we intervene on the arteries, into the MRI scanner. And the benefit of that is that we can characterize both the upstream, what's going on in the artery in the cath lab, and the downstream, what's going on in the heart muscle in the MRI scanner. And we can flick between the two, so we can really learn a lot in the early phases about what's going on. This is a complicated slide, but this just gives you some indication of what we're trying to do. This is the time of evolution of a heart attack, and these various images here that I won't dwell on in any detail are different techniques that we apply to extract information about the changes in the heart muscle that are specific to that phase of evolution of the heart attack. And we're working with physicists and Oxford physicists that sometimes we've been working for many years in the context of stable disease, to develop new techniques that we can apply in the acute phase. So I've shown you this scan before. This is just one example of how we can use contrast effects, new MRI techniques to give us additional information. So you'll remember that I said that this portion of the heart was not moving. In fact, I can show you it again. So this is the portion of the heart which is not moving. But if we give a so-called contrast agent, if you like a dye, this particular dye attaches itself to parts of the heart that have become fibrotic and scarred. Do you remember on the post-mortem sample I showed you the gristle, the white area? Well, this is a way of identifying the gristle, the white area, in a living subject. And this delineates very clearly the extent of the heart muscle that has become scarred and injured as a consequence of myocardial infarction or heart attack. So I'm showing you this because it's probably the most graphic example of how we can use relatively sophisticated imaging techniques to really bring to life the pathology, to really understand in detail what's going on in the patient's heart. One of the advantages of operating in a university environment is that we can really try and push on. And this is a slide which I think really illustrates that in two respects. I'm not going to discuss in detail what the graphs show, but use them simply to illustrate two critical points. So I showed you a moment ago this sort of effect, a bright area of scar in the heart. And that tells us, in patients who've got established scar formation, some usable information. But I will tell you that there are a number of drawbacks of applying that particular technique in the very early phase after the heart attack. And so we've been working with physicists in the department to develop novel techniques that are not reliant on the administration of any exogenous chemicals, but tell us about the physical and chemical properties of the heart muscle, particularly in the early phase after heart attack when it becomes swollen up, and allow us to make these very attractive looking colour maps delineating areas of injury. So this is an example in which we're identifying a limitation of current imaging techniques, talking to physicists and asking them to develop new techniques, and then taking them into the clinic and validating them against established applications. So that's an example where we're developing new imaging approaches. But the imaging doesn't tell you the whole story. And working with other scientists, in this case in my own laboratory, we have been analysing not the heart muscle itself, but the response of inflammatory cells in the blood. So if you have a heart attack, it turns out that one of the things that happens is you have a very dramatic influx of inflammatory cells. And they do two things. One is that in the very early phase, they seem to make the heart attack worse. They are, if you imagine inflammation in a pimple or a spot or a boil, you know how it becomes red and swollen and inflamed and angry, and the injury might actually extend for quite a distance. But then after a period of days, there's a second influx of inflammatory cells that serve to resolve and to take away all of that inflammatory material. If we could understand what those cells are doing as they arrive and while they're there, it gives us a potential opportunity to intervene and to modulate the way that they behave. And modern techniques in genomics and genetics allow us to extract those cells from the blood even before they get to the site of injury, to take out some of the genetic material called RNA, and to look in quantitative fashion at the expression level of tens of thousands of genes, perhaps 20,000 genes at a time, and to look at how they're modulated up and down, and to look at patterns of expression of genes to see which pathways, inflammation pathways, resolution pathways, are changed in the context of infarction. And then to marry up what we see happening in the response in the cells to what we see happening using the imaging. So to characterize the heart attack using the imaging so we understand what's happening in the patient, and then to lay it bare, lay it open in terms of the inflammatory response using the functional genomics. This slide, if you like, summarizes, I guess, what I've just outlined to you, that we are trying to apply a number of different approaches to get really the maximum insight into what's going on in our patient cohort. So sometimes we're applying current state-of-the-art acutely and using the opportunity to access patients in those very first hours and minutes to get novel insights. Sometimes we're developing new imaging techniques and validating them. Sometimes we're designing and developing new imaging techniques to address specific deficiencies of the sort that I showed you. And sometimes we're taking altogether new technologies and plugging them into this space. All right, so we've spoken about the upstream and the downstream already, and so far I've concentrated very much on what's going downstream in the injured tissue. And I want to have a change of tack now and look a little bit more about what's going on in the artery, which I said is where the causative pathology lies. And I'm also going to steer you away a little bit from the heart and talk about the other area of interest in the Vascular Imaging Centre, the brain. And the analogous pathology in the brain is, of course, stroke, where disease of the carotid arteries, of which one you're seeing on the screen now, and the blood clot that sometimes occurs in the carotid artery or its branches can diminish the blood supply to the brain and manifest as a stroke. So this is now an MRI scan showing a cross-section through a carotid artery. The black bit in the middle is where the blood is, and you can see that the wall of this artery has become thickened in an eccentric fashion due to the deposition of that furring or atheromatous material. So that's fat, it's calcium, it's fibrous tissue, it's the scale that occurs inside the artery. And we can use different types of MRI, magnetic resonance imaging techniques, to try and delineate some of the different constituents of the plaque. So I can tell you that when you see this particular pattern, the dark area in the middle corresponds to a pool of dead tissue that is particularly rich in lipid, in fatty components. And the combination of a fat-rich pool in the plaque, insecurely held under a thin fibrous cap, is a danger signal, because that combination lays the artery susceptible to a rupture to that cap, exposing this very, we call it thrombogenic, that means it's very prone to producing blood clots material to the constituents of the blood. And if that happens, there's a risk that this artery will become entirely obscured, blocked off by the creation of a new blood clot. So we're very interested in trying to characterize these arteries, and if possible, trying to characterize them before they cause mischief. This is an example, however, of characterizing arteries not before they've caused mischief, but afterwards. So it turns out that if you have a stroke, the maximum risk, or if you have a mini stroke, a TIA, or a transient ischemic attack, the maximum risk of having a major stroke is within the first 48 hours, certainly within the first week of that early manifestation. And so we took the trouble to try and image the carotid arteries of patients very early, in fact a median of just 2 days after the mini stroke, to see if we could identify features of the coronary artery that would predict which patients would go on and have a stroke, because of course if we could do that, we would open up an opportunity, a window in which we could intervene specifically in those patients and hopefully reduce the risk. And I'm just showing you here some of the features that we see in carotid arteries early after a stroke. So this is a fissured plaque, a nasty cut in the surface of that plaque. This is another example in which we see this bright represents blood, a hemorrhage within the plaque, which is another precipitant of blood clot downstream and stroke, and in fact turns out to be the strongest predictor of downstream injury. So we measure the downstream injury by combining these images of the carotid arteries with virtually concurrent imaging of the brain, and you can see this white area here corresponding to brain injury, which is due to a blood clot that has formed in situ in this carotid artery. So really trying to understand the relationship between the upstream in the carotid artery and the downstream in the brain. So let me end there by simply summarising what I think we've covered, what I hope we've covered, which is that we are working towards, through collaboration of university and hospital, supported by the NIHR Oxford Biomedical Research Centre, an extensive programme of research both in heart attack and in stroke that builds on our delivery of a clinical service which we believe is of good quality in serving the local community well. It's a partnership not only between the university and the trust, but it is highly dependent on the engagement and interaction of our patients and their relatives and the local community. And we're very pleased to say, that I haven't shown you any data today, that our patients would appear to be very enthusiastic supporters. From the uptake rates and the engagement in research, the numbers of patients who are pleased to go through these scanners, we think that this is a genuine partnership, and we are keen, as often as is possible, to share our work with the community. And I hope that today's presentation, and I hope the discussion that follows will be one such opportunity. So thank you very much for your attention, and if you do have any questions, I will be delighted to try and answer them. Thank you.